Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be continuing our discussion of adult lymphomas with an overview of non-Hodgkin lymphoma. Non-Hodgkin lymphoma, or NHL, is a very heterogeneous entity. Broadly, non-Hodgkin lymphoma basically encompasses any cancers that are originating from cells that differentiate into B and T cell lymphocytes. And so these may arise either from the bone marrow or from peripheral nodal tissues. B cell lymphomas probably make up around 85 to 90% of non-Hodgkin lymphomas. They are way more common than T cell lymphomas. The easiest way to sort of divide non-Hodgkin lymphoma and to split it into two groups and think about their different treatment paradigms is to divide non-Hodgkin lymphoma into aggressive versus indolent histologies. So aggressive non-Hodgkin lymphoma are probably a little bit more common, making up 50 to 60% of NHLs. They tend to be more common in low to middle income countries. And they're aggressive. So the estimated survival is months without treatment. So on the order of months, much shorter than for indolent lymphomas. There are both B and T cell lymphomas that can be common histologies. With B cell lymphomas, DLBCL or diffuse large B cell lymphoma is probably the most common histology. Primary mediastinal lymphoma can also be common. There's something known as high-grade follicular or grade 3B lymphoma, which we'll talk about. Mantle cell lymphoma is an aggressive B cell lymphoma, as well as Burkitt lymphoma. There's something called gray zone lymphoma. I put that in italics just because it is thought of as kind of an intermediate between DLBCL and Hodgkin lymphoma. There are different T cell lymphomas as well, such as peripheral T cell lymphoma, anaplastic large cell, angioimmunoblastic, extranodal NKT cell nasal type, which tends to be very, very aggressive. And then lymphoblastic lymphoma can be B or T cell. So lots of different types of lymphomas just within the aggressive category, broadly divided into B cell versus T cell lymphomas. DLBCL is by far the most common aggressive lymphoma that we see. And in terms of treatment, it's typically going to be multi-agent chemotherapy with or without involved site radiotherapy. And the chemotherapy regimens that we see are typically based on rituximab. So R-CHOP is the most common, and we'll talk about what that is. But the R stands for rituximab, which is an anti-CD20 antibody. And the reason that that is used is because most of the time these are B-cell lymphomas, and CD20 is a B-cell marker. So it specifically targets the B cells. Now, in terms of indolent lymphomas, these tend to affect more older adults, so age 65 plus. They tend to be more common in well-developed countries like North America, Europe, Australia. Without treatment, they can sometimes just be observed with an estimated survival on the order of years to decades, so much, much longer than these aggressive lymphomas. In terms of common histologies, follicular lymphoma is very common, and so low-grade follicular lymphomas are thought of as grade 1 to 3A, and we'll talk about what distinguishes follicular lymphoma grades 3A, which is still considered indolent, versus 3B, which remember was considered aggressive. Marginal zone lymphomas, gastric malt, which is an extranodal marginal zone lymphoma, orbital lymphomas. These are indolent B cell histologies. And then there's also mycosis fungoides, which is a cutaneous T cell lymphoma. For limited stage indolent lymphomas, oftentimes the treatment can just be definitive radiation alone. And so that's a very broad overview of aggressive versus indolent non-Hodgkin lymphomas. Keep in mind that these may occur on a spectrum, and sometimes indolent histologies can transform into an aggressive subtype, and sometimes aggressive subtypes can even transform into leukemia. So keep in mind that things can happen on a spectrum, and this is a very kind of broad and simplistic way of dividing into aggressive versus indolent. In the next talk, we'll get into the evidence behind the management of non-Hodgkin lymphoma, but for the overview lecture, what I'd like to focus on is the presentation and workup, staging and risk stratification, and then finally an overview of the treatment paradigm for non-Hodgkin lymphomas. So let's start with the basics. Most commonly, Hodgkin lymphoma will present with a painless enlarging lymph node. It may be associated with things like fatigue, malaise, low-grade fever. Remember, anytime we're working up patients for lymphoma, we always want to ask about B symptoms, and there are 3 specific symptoms that qualify as B symptoms, so greater than 10% unintentional weight loss in a period of 6 months, fever greater than 38 degrees Celsius, or drenching night sweats. And these B symptoms tend to be more likely with aggressive histologies or extensive disease versus more indolent and limited stage disease. If patients have skin involvement, which is certainly possible because there are a lot of different cutaneous lymphomas as well, that may be associated with a rash or pruritus. Patients may present with hepatomegaly, splenomegaly, so we always want to examine them for organomegaly. Bone marrow involvement is common for indolent lymphomas, and you'll see that when we are suspicious of an indolent lymphoma, we do want to get a bone marrow biopsy. Especially for early stage disease. And then sometimes the presentation just may be cytopenias that are detected on labs. In terms of workup, remember we always start with a full history and physical. We should always inquire about those constitutional symptoms, so the B symptoms that we just mentioned, examine for large lymph nodes and hepatosplenomegaly. In terms of labs, we can obtain a CBC with a differential, ESR, CMP, LDH, uric acid. Patients should be tested for Hep B and Hep C as well as HIV. And if appropriate, also consider ordering a pregnancy test. For gastric malt, we can diagnose that with a urea breath test as well. In terms of imaging, PET-CT is probably the gold standard. An MRI can be considered for something like primary CNS lymphoma or nasal type NKT cell lymphoma. In terms of pathology, ideally we would obtain an excisional biopsy of the most FDG-avid area. Keep in mind that for lymphomas, FNA is insufficient for histologic grading, so you cannot just obtain an FNA. If an excisional biopsy is not possible, then core needle biopsy is a less ideal alternative. So you can say excisional or a core needle biopsy, but FNA is not adequate. Once we have that biopsy, we do perform immunophenotyping with IHC and flow cytometry, and then we also perform genomic profiling with FISH to detect major translocations. In terms of consideration for bone marrow biopsy, you can refer to NCCN for kind of detailed guidelines depending on the specific lymphoma that we're talking about. In certain cases, bone marrow biopsy is essential, but I'll go over 2 of the most common scenarios. So the first common scenario is DLBCL, which remember is the most common aggressive non-Hodgkin lymphoma. For DLBCL, bone marrow biopsy can actually be omitted most of the time. So if bone marrow is diffusely positive on PET-CT, then you know it's involved. Or if there is clearly no skeletal uptake on PET-CT, then you know it's not involved. And so in DLBCL, bone marrow biopsy actually can be omitted. In follicular lymphoma, however, and remember follicular lymphoma is typically an indolent lymphoma, bone marrow biopsy actually is necessary to document stage 1 to 2 disease. If the initial therapy is just going to be observation, which is an option for indolent lymphomas that are early stage, then we can defer the bone marrow biopsy. But if we definitely want to treat something as an early stage follicular lymphoma with definitive radiation, for example, bone marrow biopsy should be obtained to document stage 1 to 2 disease. And that's just because bone marrow can frequently be involved with indolent lymphomas. There are certain situations where we would consider obtaining a lumbar puncture and probably neuroaxial imaging along with that. And think of involvement of the protected sites. So things like testicular involvement, paranasal sinus, paravertebral or parameningeal, as well as eye involvement. I just briefly wanted to take a moment to remind ourselves of the anatomy of a lymph node, so sort of the lymph node architecture. Remember, on the outside is the capsule, followed by the subcapsular sinus, and the cortex, which is made up of follicles and germinal centers, is really the B cell zone. So the B cell zone consists of follicles and germinal centers, and that is in the cortex of the lymph node. And then the T cell zone is really the paracortex. And then from there, we have the medullary sinus, the medullary cord, which ultimately leads into the hilus of the lymph node. Before we move on and get into the staging, I want to take a moment to talk about a few aspects of workup that are important for some of the most common types of lymphoma that we see. So the most common type of aggressive lymphoma that we see by far is called diffuse large B-cell lymphoma. And there's just a couple of points I want to make about the workup of diffuse large B-cell lymphoma. So one thing to be aware of is that DLBCL is divided into two subgroups based on gene expression profiling using what is known as the Hans algorithm. So they basically take, they look at expression of particular genes, including CD10, BCL6, and MUM1, and based on the expression of these different genes using the Hans algorithm, B-cell lymphomas are divided into germinal center B-cell-like DLBCL, or GCB, germinal center B-cell-like, versus activated B-cell-like, also known as non-GCB. So you might hear GCB versus ABC, or you might hear GCB versus non-GCB. And what's important to note is that germinal center B-cell-like typically has a better prognosis compared to the activated B-cell-like. So activated B-cell-like, or non-GCP, typically has a worse prognosis compared to the germinal center B-cell-like. I think it makes a little more sense if you think about where these malignant cells are coming from. So in germinal center B-cell-like, the cancerous cells are arising from malignant B cells that have the same genetic expression profile of normal germinal center B cells, such as CD10 expression, as you can see in the Hans algorithm. The activated B cell-like, or the non-germinal center B cell lymphoma, is actually coming from post-germinal center B cells that are on their way to becoming plasma cells. So I sort of think of the activated B cell-like as cells that are on the next step on the way to becoming plasma cells, and that's how I remember that they're just more aggressive. The clinical relevance of this is that some folks may actually consider intensifying the chemotherapy regimen for the activated B-cell-like, knowing that it has a worse prognosis compared to germinal center B-cell-like lymphoma. So big takeaway here is Hans' algorithm helps us to identify two subtypes of DLBCL, germinal center B-cell-like versus activated B-cell-like. Activated B-cell-like are further along in the differentiation process of B cells. They're on their way to becoming plasma cells, and so they tend to be more aggressive. The other thing that's really important to know for DLBCL is three proto-oncogenes that we test for using cytogenetic testing or FISH testing, looking for particular rearrangements. So all of these proto-oncogenes that we are about to discuss are involved in regulating cell proliferation, right? Because cancer is just uninhibited cell division. And so all of these proteins in some way, shape, or form regulate cell proliferation. So these genes are BCL2, BCL6, and MYC. And these genes are all involved in regulating cell proliferation. BCL2 and BCL6 typically function to inhibit apoptosis. And the reason they're considered proto-oncogenes is because they inhibit apoptosis, right? They prevent cell death. And so if their expression is unregulated, then they will inhibit apoptosis like crazy, causing cells to remain alive and continue to proliferate. And that's really that's what causes cancer. And so the way that I remember, and this becomes important for radiation biology, the way that I remember the function of BCL2 and BCL6 to inhibit apoptosis is I think of the phrase buckle up to stay alive. So BCL, buckle up to stay alive. The BCL genes inhibit apoptosis. And then c-Myc, which is located on chromosome 8, also regulates expression of genes that control cell proliferation. So the reason it's important to get an adequate biopsy when we perform biopsy, remember we said either excisional or at least a core biopsy, is so that we can perform FISH testing and look for these rearrangements. If MYC on chromosome 8 is rearranged with either BCL or BCL6, that is known as a double hit, so double hit lymphoma. Sometimes it can be rearranged with both, and then it's called a triple hit lymphoma. Sometimes, however, instead of just a rearrangement, you can have co-expression of the c-Myc and BCL proteins without any underlying genomic rearrangement. So it's not a rearrangement, it's just a co-expression. And if that happens, it's known as a double expressor lymphoma. So both of these are poor prognostic factors, double hit as well as double expressor, but double hit is worse than double expressor. And the way that I remember that, it's just in the name, right? If somebody hits you, think of that as really bad versus just expressing anger. That's sort of my silly mnemonic to remember this. So double hit is a worse prognosis, and of course triple hit as well compared to double expressor. So these are some very important proto-oncogenes for DLBCL, and keep in mind that they can either be just co-expressed or there can actually be an underlying rearrangement. And if that underlying rearrangement is present, then that is known as double hit or triple hit if it's with both MYC and BCL2 as well as MYC and BCL6. And the hit is worse than the expressor. And again, the clinical relevance of that, similar to what we talked about with activated B-cell lymphoma, is that if patients do have double or triple hit, DLBCL, we might consider escalating the chemotherapy for those patients. So that was a little extra intel on our most common aggressive non-Hodgkin lymphoma, which is DLBCL. I want to take a moment now to talk a little bit about the grading system for follicular lymphoma, which is typically our most common type of indolent lymphoma. And remember, indolent lymphomas behave very differently than aggressive lymphomas, and they oftentimes, if they are early stage disease, do not require any chemotherapy. So follicular lymphoma is graded based on the number of centroblasts. And I tried to include a picture to elaborate on what a centroblast is. It's basically an activated B cell that is enlarged and rapidly proliferating in the germinal center of a lymphoid follicle, so typically in the dark zone of a lymph node. And so it's graded based on the number of centroblasts. Grade 1 is 0 to 5 centroblasts per high-powered field. Grade 2 is 6 to 15 centroblasts per high-powered field. And then grade 3 is divided into 3A versus 3B. In general, 3 means greater than 15 centroblasts per high-powered field. With 3A, there are centrocytes present. With 3B, what we see is solid sheets of centroblasts. And remember that follicular lymphoma grade 3B is distinct from other types of follicular lymphoma, and it is actually treated as a high-grade lymphoma. So whereas all the other follicular lymphomas would be managed with definitive radiation alone if they were early stage, for follicular lymphoma, it's treated as a high-grade lymphoma, and so we would give upfront systemic therapy. Just to sort of round out our discussion of the different types of lymphoma, I have a couple of tables. So this first table has some of the common B-cell lymphomas divided into aggressive versus indolent histologies. Remember that B-cell lymphomas are classically CD19 and CD20 positive. Those are typically the markers that are seen on B cells. And so there, in this table, are all of the different types that we already talked about. There are some classic genetic translocations that are associated with these. So I'm not going to sort of list them out, but there is kind of the classic genetics as well as the description of some of these aggressive versus indolent lymphomas. And these are things that can show up on board exams and things like that. And so I will just sort of leave that here for your review. Similarly, here is a table with some of the common T-cell lymphomas also divided into aggressive versus indolent. And again, these are some of the lymphomas that we already mentioned earlier, but a little bit more detail, as well as some of the classic genetic profile of some of these, which again, we'll just leave here for your reference. Moving on then, let's talk about staging and risk stratification. Non-Hodgkin lymphoma staging is basically identical to what we talked about for Hodgkin lymphoma, if you listen to the overview lecture on Hodgkin lymphoma. It's staged using what is known as the Ann Arbor staging. It's also called Ann Arbor-Lugano because there have been some updates based on the Lugano system. So the diseases are broadly classified as stage 1 through 4. I think of stage 1 to 2 as disease really on just one side of the diaphragm, and 3 to 4 involving both sides of the diaphragm, or a lot of non-contiguous extralymphatic involvement. So stage 1 is really just one node or group of adjacent nodes, or a single extranodal lesion without nodal involvement. So just one area is stage 1. Stage 2 is more than one nodes on the same side of the diaphragm, or stage 1 to 2 by nodal extent with limited extranodal involvement that is contiguous to the nodal disease. Stage 3 is if there are nodes on both sides of the diaphragm or nodes above the diaphragm with splenic involvement. And then stage 4 is additional non-contiguous extralymphatic involvement. Now, in Hodgkin lymphoma, we typically will add some modifiers such as A or B based on whether or not the patients have B symptoms. X is added for bulky disease, and E is added for extranodal disease. The 2014 Lugano update largely gets rid of these. So it says that X and A and B modifiers are no longer needed for non-Hodgkin lymphoma, and E is unnecessary for stage 3 to 4 disease. So that's just based on the 2014 Lugano update. So just remember the modifiers are typically more commonly used with Hodgkin lymphoma. With non-Hodgkin, we don't add them in as much. Just as we talked about the International Prognostic Score for risk stratification in advanced stage Hodgkin disease, there are also some international prognostic indices to be aware of. So the first one that we'll talk about is the International Prognostic Index, or IPI, for aggressive non-Hodgkin lymphoma. Now, this doesn't really affect our management, to be honest. It doesn't truly affect our management of the disease, but it just gives us sort of a risk stratification that does, in studies, it has corresponded to survival outcomes. And so really, this is a prognostic tool, not really a predictive tool, but it gives us a prognosis. So the classic mnemonic for the IPI for aggressive non-Hodgkin lymphoma is LAKES. So LDH, age over 60, the KPS or performance status, so KPS 70 or worse, or an ECOG of 2 or worse, extranodal sites, so if you have 2 or more extranodal sites, and then the stage, or stage 3 to 4 disease. So this International Prognostic Index, I use the mnemonic LAKES. The other mnemonic you might hear is LEAPS, which stands for LDH, extranodal site, age, performance status, and stage. Same exact thing, different mnemonic. Each of these items in that acronym gets a score of 1 if they are present. And then based on the score, the total score, when you add them all up together, we get a risk group, and that risk group corresponds to prognosis. And so these just typically have prognostic utility. As I said, they don't really affect our management. One thing that you might see that's used is something called a stage-adjusted IPI. And so instead of giving a point for stage 3 to 4 disease, stage-adjusted IPI uses stage 1 versus 2, and they give a point for stage 2 and no points for stage 1. You might also see age-adjusted IPI, which similarly uses cutoffs based on the age. And so this is kind of the classic IPI that I have here on this slide. And then there are some more modern indices that just may have improved prognostic utility. For follicular lymphoma, the International Prognostic Index is called FLIPI, so it's just the follicular lymphoma IPI. And so the original FLIPI score was created in a pre-rituximab era, and it included things like hemoglobin level, age over 60, more than 4 nodal sites, stage 3 to 4 disease, and elevated LDH. In the era of rituximab, the FLIPI does remain prognostic. However, the FLIPI-2 system incorporates a few additional factors, and it was actually applied to a cohort that did receive chemoimmunotherapy. And so FLIPI-2 uses things like hemoglobin, age. They also add the serum beta-2 macroglobulin level, bone marrow involvement, and tumor size greater than 6 centimeters. So again, those are just some scores to be aware of, especially that Lakes mnemonic for the International Prognostic Index might get tested. These are prognostic tools. They have not yet been validated as any sort of predictive tools, and so we don't really change our management based on them. They don't predict that a patient will have a certain response to a particular therapy versus another. They are just prognostic for overall survival outcomes. So let us move on now and briefly review some of the treatment paradigms for non-Hodgkin lymphoma. So management of non-Hodgkin lymphoma really depends on whether it is an aggressive or an indolent lymphoma. As we said earlier, the aggressive lymphomas tend to get more systemic therapy up front, with or without involved site radiotherapy, depending on the response. And indolent lymphomas, especially if they are limited stage disease, can just be treated with definitive involved site radiotherapy. And then, of course, for any advanced stage disease, radiation can also be used as a palliative option. So here on this slide, I've kind of outlined the management of two of the most common lymphomas that we see, DLBCL being our most common aggressive lymphoma, and then follicular lymphoma, which is our most common indolent lymphoma. So with DLBCL, I think the trend is very similar to what we saw with Hodgkin lymphoma, where the use of radiation in general has been declining, especially with more effective systemic therapies. And for non-Hodgkin lymphoma in particular, the advent of rituximab, which is that anti-CD20 antibody, has been critical in improving outcomes for lymphoma. So we'll talk about this more in detail when we get into the evidence lecture in the next talk. But just as a little bit of background, the standard chemotherapy used to just be CHOP, and we'll talk about what all of those drugs are here in a minute. But the role of radiation was really established in a pre-rituximab era. And then when rituximab came out, we learned that rituximab was actually very, very effective at treating lymphoma. And so studies moved towards exploring just R-CHOP regimens without involved site radiotherapy after. And so when it comes to the treatment paradigm for DLBCL, your classic germinal center type average risk DLBCL, and keep in mind that we also treat grade 3B follicular lymphoma this way, as similar to a DLBCL. Starting off with R-CHOP for 3 to 4 cycles is probably the right answer. And after 3 to 4 cycles of chemotherapy is typically when we would acquire a PET-CT. After a patient has received up to 4 to 6 cycles of R-CHOP, we might consider radiation as consolidation for bulky disease, so disease measuring more than 7.5 centimeters, or if they have skeletal involvement. And in the next talk, we'll kind of discuss the studies that lead us to that conclusion. Or if the patients are only receiving 3 cycles of R-CHOP, then we can consider adjuvant ISRT 30 to 36 gray if they have a complete response, or 40 to 50 gray if they have a partial response. If they have stage 1 to 2 disease and they have a complete response after 3 cycles of R-CHOP, we can either follow that with 1 cycle of R-CHOP or ISRT. So there's a lot of options here. A lot of the times patients with DLBCL are just going to get 4 to 6 cycles of R-CHOP and call it a day. But as radiation oncologists, it's important for us to know when we might want to treat with radiation. And so if they only received 3 cycles of R-CHOP, or if they require consolidation for either bulky disease or skeletal involvement. Now, remember we mentioned that there are some other types of DLBCL that are a little bit more aggressive, and in those cases, folks might consider escalating the chemotherapy or kind of intensifying treatment. So for activated B cell type, remember that ABC or the non-germinal center type lymphoma was more aggressive. Some favor intensifying chemotherapy, providing either R-CHOP times 6 to 8 cycles instead of 4 to 6, with or without ISRT, or even using more aggressive chemotherapy regimens. For double or triple hit lymphomas, a similar concept, and people might treat with R-EPOCH, which is kind of a more aggressive form of R-CHOP. We just add etoposide in that case, or R-hyper-CVAD. And for double or triple hit lymphoma, they might even consider CNS prophylaxis with something like methotrexate or autologous stem cell transplant. And then the last subtype I'll mention is something called primary mediastinal DLBCL, which is a different entity than other forms of DLBCL. And for this as well, we tend to give more aggressive chemotherapy. So either R-EPOCH times 6 cycles with or without involved site radiotherapy, or R-CHOP times 6 cycles with ISRT. Moving on then to follicular lymphoma. So remember, grades 1 to 3A follicular lymphoma are considered indolent. And for limited stage follicular lymphoma, so stage 1 to 2, we can just treat with definitive involved site radiotherapy to 24 to 30 gray. And that's kind of the preferred modality, and these patients don't really need chemo. For advanced stage indolent lymphomas, so now we're talking stage 3 to 4 with disease on both sides of the diaphragm or non-contiguous extranodal involvement, observation is actually an option. We may also treat with rituximab-based chemotherapy, or we can treat with palliative radiation. And we'll talk more in the next lecture on the 4 gray and 2 fraction palliative approach. Oftentimes this is called boom boom. So 2 gray times 2 or 4 gray and 2 fractions, boom boom. It has been shown in studies to provide equal symptomatic relief. It just provides less durable local control. It is a pretty effective therapy, though, if you're treating something like orbital lymphoma. It really, really spares toxicity, causing essentially no toxicity. And if patients fail after 4 gray times 2 for something like orbital lymphoma, we can always come back and provide additional consolidation radiotherapy. Keep in mind that follicular lymphomas, people often say that they're kind of like daisies. So you treat one somewhere and then another one might pop up elsewhere. They are just slow growing, indolent. It's hard to make them completely go away. So it's possible if you treat someone for limited stage follicular lymphoma, they might develop some other site down the road and they might need further treatment. And so that is why for these lymphomas, observation is also an option if patients wish to defer treatment. So getting into some more specifics about the therapies that we might use, starting with systemic therapy. So in terms of the systemic therapy regimen, R-CHOP is typically what is standardly used up front for aggressive lymphomas. So think DLBCL. Remember, we typically start with R-CHOP times 3, get a PET scan, and then we do 4 to 6 cycles total depending on the response, plus or minus involved site radiotherapy. So what is in R-CHOP? What are all the drugs? So R stands for rituximab, which remember is our anti-CD20 antibody. The C is cyclophosphamide. The H is doxorubicin. H comes from hydroxydanorubicin, I believe, which is just another name for doxorubicin. The O is vincristine, and that name comes from Oncovin, which is the brand name. And then P is prednisone. So rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. And R-CHOP is typically given every 3 weeks for up to 6 to 8 cycles. So anywhere from 4 to 8 cycles. Remember, we also mentioned R-EPOCH, which is an alternate, more intensive regimen. given to patients with double or triple hit lymphoma or patients with primary mediastinal B-cell lymphoma. So our EPOCH has all of the same agents as R-CHOP plus etoposide. And it's not beneficial for all DLBCL subtypes, but it is an option to consider for primary mediastinal or double hit DLBCL. And then we get into the role of radiotherapy for non-Hodgkin lymphoma. And remember, the role of radiation is going to be very different depending on if we're talking about aggressive versus indolent non-Hodgkin lymphoma. In aggressive histologies, the role of radiation is usually for consolidation or palliation. In consolidation, we can consider radiation if we have bulky sites that are 7.5 centimeters or larger, or if there are areas of skeletal involvement. And in terms of typical dosing, so we can consider 30 to 36 gray if we're using it for consolidation after a complete response. If patients have had a partial response, then we can do 40 to 50 gray. And if we're using radiotherapy as a primary treatment in a situation where a patient is not a candidate for chemotherapy, again, we can consider higher doses, so 40 to 55 gray. And sometimes you might see that we're combining R-CHOP with stem cell transplant, and it can be used as a bridge to stem cell transplant or CAR T-cell therapy or something like that. And in those cases, we might even consider lowering the dose, something like 20 to 36 gray. For indolent non-Hodgkin lymphoma, remember that radiation can actually be used definitively if we have limited stage disease, or if there is extensive stage disease, then we can often use it for palliation. So if we're treating something definitively, the dose would be somewhere between 24 to 30 gray. And there's a pretty famous study, which we'll talk about in the next talk, that comes from Lowry et al., that actually showed that 24 gray was enough. So I've typically just seen 24 gray for definitive radiotherapy for limited stage indolent lymphomas. And in this case, when we're doing our ISRT, we want to be pretty generous with our margins, just because patients will not be receiving any systemic therapy for microscopic disease. And there are actually very good guidelines from ILROG for contouring for all different types of lymphoma. In terms of the palliative dosing, remember we talked about that boom-boom regimen, which is 2 gray times 2, 4 gray and 2 fractions. And there's a study called the FORT trial, again, we'll talk about that in the next lecture, which showed that 4 gray times 2 can actually provide equivalent symptomatic control. It has less durable local control, but it's pretty effective for symptomatic control. And there are, newer studies coming out from MD Anderson, for example, that actually shows 4 gray times 2 can lead to a very good response for something like orbital malt lymphoma. And if patients, for whatever reason, don't respond, and it's almost a 90% response rate to 4 gray times 2, which is fairly good. But if patients don't respond, we can always come back with more consolidation radiotherapy and take them to 24 gray. I want to end by talking about some unique types of lymphoma, including extranodal and primary cutaneous lymphomas. So I have 2 slides on each of those topics. These slides, I've created tables that are largely summaries of management from ILROG guidelines that exist for these types of lymphoma. And I would refer you to those ILROG guidelines because they are much more detailed and very useful reference anytime you're treating any of these sites. But just to be aware of some special considerations, starting with some of the different types of extranodal lymphomas. So one of the sites that extranodal lymphoma can occur in is CNS. You might have a primary CNS lymphoma. And the standard radiotherapy treatment for primary CNS lymphoma would consist of whole brain radiation to 24 gray after a complete response to chemotherapy, or 30 to 36 gray if they have a partial response to chemotherapy. And there's not a benefit to involved site boost, and the CSF is typically treated with intrathecal chemotherapy with something like methotrexate, not with craniospinal irradiation. For orbital lymphoma, the dose really depends on histology. So if it's something indolent, such as a malt lymphoma, remember we said 24 gray is adequate, and the new data I just referenced from MD Anderson also shows that 4 gray and 2 fractions is, very, very minimal toxicity, and up to 90% of patients might actually have a pretty good response to that. If it's DLBCL, though, then for an orbital lymphoma, you would still do 30 to 36 gray. NK T-cell lymphoma nasal type is a highly aggressive type of lymphoma, and it requires very high doses that are greater than or equal to 50 gray, and certain unique chemotherapy regimens. There's a chemotherapy regimen called SMILE for NK T-cell nasal type lymphoma, which SMILE chemotherapy to me just reminds me of a horror movie, that name for some reason. But SMILE chemotherapy followed by 45 to 50.4 gray, Gelux chemotherapy followed by 56 gray, or DeVic with concurrent 50 gray. These are requiring, all these regimens are requiring on the order of 50 gray or up. And oftentimes we can evaluate the response after 50 gray and then boost any residual disease if there is any with an additional 5 to 10 gray. So NK T-cell lymphoma nasal type, very, very aggressive, requires 50 to 60 gray. Gastric malt lymphoma is unique because remember that is the one type of cancer that can actually be treated and sometimes cured with antibiotic therapy alone if it is H. pylori positive. So we utilize triple therapy or quadruple therapy with antibiotics to treat the H. pylori. There is a genetic translocation that can be associated with gastric malt lymphoma. That translocation is T1118. And if that translocation exists, then those lymphomas actually tend to be less likely to respond to antibiotic therapy. And so if they persist after antibiotic therapy, then we might need to do involved site radiotherapy with 30 gray typically, and it's often given at 1.5 gray per fraction just to be a little bit gentler on the stomach. And it might require treatment to the entire stomach volume, plus or minus any regional lymph nodes if those are involved. And then finally, the last extranodal lymphoma I'll mention is testicular lymphoma, which is also a little bit unique in that it is a sanctuary site. So normally testicular lymphoma will be treated with an orchiectomy of the involved testis, and we do need to provide CNS prophylaxis, again with methotrexate. And then we also need to provide prophylactic radiotherapy to the contralateral testes, regardless of the response to chemotherapy, using something like 24 to 30 gray. And so that's just a unique site because testes is a sanctuary site, so we need to take care of the CNS and also radiation to the contralateral testes. The final unique type of lymphomas that I'll mention are primary cutaneous lymphomas, which again tend to be very heterogeneous entity, very different treatment paradigms depending on the histology. So primary cutaneous follicular central lymphoma, marginal zone lymphoma, or anaplastic large cell lymphomas are often treated just with involved lesion radiotherapy to 24 to 30 gray. Primary cutaneous DLBCL leg type is a very specific type of, primary cutaneous DLBCL, and it's treated with R-CHOP times 6 cycles followed by 36 to 40 gray, and we go up to 40 gray if the patients did not receive any systemic therapy. You can get a primary cutaneous NKT cell lymphoma, and again, remember that was the very aggressive lymphoma, and again, that requires 50 to 60 gray of radiation, 50 gray to the initial lesion with a 5 to 10 gray boost to any residual disease. And then finally, we have mycosis fungoides, which is a type of cutaneous T-cell lymphoma. And if the mycosis fungoides is limited stage, so if you just have one lesion or something like that, the dose is 24 to 30 gray for a definitive radiation scenario where you're trying to cure the patient. Oftentimes, however, and pretty much all of the mycosis fungoides patients that I've ever seen sort of have disseminated disease, and they have many different areas of skin involvement. And so we are often consulted for radiation to palliate these lesions, and the dose for palliation is something like 8 to 12 gray at 3 to 5 gray per fraction. The most common dose fractionation regimen that I've seen used is 8 gray delivered in 2 fractions, so 4 gray times 2 fractions. And then if patients have significant involvement, like greater than 50% of the skin involved with mycosis fungoides, total skin electron beam therapy is additionally something to consider. Historically, the dose was 30 to 36 gray in BID treatments over 9 weeks. But in the modern era, I think we are moving more towards 10 to 12 gray with repeat total skin electron treatment for refractory disease. So that brings us to an end of everything I wanted to discover in terms of an overview of non-Hodgkin lymphoma. And I know that was a lot of information. There are many different types of lymphoma, and a lot of them have a very unique treatment paradigm. So if you take away anything from this overview lecture, remember that non-Hodgkin lymphoma is a very heterogeneous entity. And very broadly, we can divide it into aggressive versus indolent types. Remember that for aggressive non-Hodgkin lymphoma, generally we go for rituximab-based chemotherapy, so often R-CHOP is the regimen that we go to, with or without involved site radiotherapy. And if we do utilize radiation, then the dose is 30 to 36 gray for consolidation after a complete response, or 40 to 50 gray if patients have a partial response, or if we're just treating them and they've received no chemotherapy. For indolent non-Hodgkin lymphoma, so 1 to 3A or grade 1 to 3A follicular lymphoma, for example, for limited stage disease, we can treat with radiation alone. 24 gray is sufficient. Oftentimes textbooks will say 24 to 30 gray. And if patients have advanced stage disease, we can consider the boom-boom regimen, which is 4 gray delivered in 2 fractions just for palliation. I hope this was a hopeful overview. In the next lecture, we will delve more into the evidence for why we do what we do when it comes to non-Hodgkin lymphoma. Thank you.